Welcome to our last video on diseases of the esophagus. Let's begin. We'll finish this series of lectures by talking about dysphagia, odynophagia, and gastroesophageal reflux disease. Let's talk about dysphagia, and we'll address the definition, risk factors, pathophysiology, clinical presentation, diagnosis and management of dysphagia and odynophagia. Dysphagia is difficulty swallowing. Odynophagia, on the other hand, refers to painful swallowing. The major risk factor of dysphagia to solid foods is mechanical obstruction. Examples of mechanical obstruction of the esophagus include esophageal webs, strictures, and cancer. The main risk factor of dysphagia to solids and liquids is disrupted peristalsis. Examples of disrupted peristalsis include diffuse esophageal spasm, Zenker diverticulum, echalasia, and prior stroke. Let's move on to odynophagia. One of the strongest risk factors of odynophagia is infection by either herpes simplex virus, cytomegalovirus, or Candida albicans. Another risk factor of odynophagia is caustic ingestion. As we already mentioned, dysphagia is caused by mechanical obstruction or disrupted peristalsis. This will cause slow food transit or food retention in the esophagus. Therefore, the patient feels as if food is stuck in the esophagus. Odynophagia, on the other hand, is mostly due to infection or caustic injury. These processes cause mucosal infiltration by leukocytes. Local inflammation begins, and the patient experiences pain due to swallowing-induced stimulation of inflamed esophageal mucosa. Except for difficulty swallowing and painful swallowing, dysphagia and odynophagia may be accompanied by fever, weight loss, retrosternal pain, and heartburn. Accompanying symptoms depend on the specific underlying cause of dysphagia and odynophagia. Most common studies used to diagnose the specific cause of dysphagia or odynophagia include barium swallow, esophageal manometry, and endoscopy with biopsy. The best initial study is determined by the suspected cause of swallowing problems. Management of dysphagia and odynophagia is focused on treating the underlying cause. Treatment may include surgery, pneumatic esophageal dilation, botulinum toxin injection, or antimicrobial agents. A 58-year-old man with a history of adult polycystic kidney disease presents to the physician with odynophagia, dysphagia, and low-grade fever for 6 months after bilateral kidney transplant. He takes sirolimus and hydrocortisone. What's the best initial diagnostic test for this patient's condition? This patient presents with odynophagia, dysphagia, and low-grade fever 6 months after bilateral kidney transplant. He takes sirolimus and hydrocortisone. Therefore, he is immunosuppressed. Odynophagia and dysphagia in a patient taking immunosuppressant drugs suggests infectious esophagitis. The best initial diagnostic test for suspected infectious esophagitis is endoscopy with biopsy. We'll finish this lecture by discussing the gastroesophageal reflux, or GERD. We will address definition, risk factors, pathophysiology, clinical presentation, diagnosis, and management of GERD. Gastroesophageal reflux disease, as the name implies, is gastric acid reflux in the esophagus. One of the strongest risk factors for GERD is obesity. The increase in visceral fat elevates the external pressure on the stomach, stimulating acid reflux in the esophagus. Pregnancy is another well-established risk factor of GERD. Gravid uterus exerts external pressure on the stomach, inducing acid reflux. Smoking, spicy foods, and sour foods, and certain drinks like coffee and alcohol can exacerbate GERD. Finally, hiatal hernia and scleroderma also predispose to acid reflux. Let's talk about pathophysiology of GERD. Acid reflux from the stomach to the esophagus causes acid-induced distal esophageal injury. This in turn causes inflammation of esophageal mucosa and the classic symptoms that we will discuss in the next slide. The classic symptom of GERD is heartburn. Heartburn is the retrosternal burning pain due to acid reflux in the esophagus. Sour taste in the mouth is due to acid reflux all the way to the oral cavity. Nocturnal cough results from laryngeal irritation by acid. If the acid reaches the bronchi, then the patient may experience the adult-onset asthma due to chemical irritation of the bronchi. Chronic GERD can cause Barrett esophagus. Barrett esophagus is an intestinal metaplasia of distal esophageal epithelium. In other words, chronic acid exposure converts normal esophageal epithelium to simple columnar mucinous epithelium. Persistent Barrett esophagus, in turn, increases risk for esophageal adenocarcinoma. This is how Barrett esophagus looks like on endoscopy. We can appreciate those dark pink patches, different from the normal esophageal mucosal color. These patches indicate intestinal metaplasia. And this is how Barrett esophagus looks like under light microscopy. We can see simple columnar ciliated epithelium, different from the normal esophageal epithelium. Keep in mind that persistent Barrett esophagus is a risk factor for esophageal adenocarcinoma. Diagnosis of GERD is mostly clinical. However, there are certain situations when we should perform endoscopy. Endoscopy is indicated if the patient is a man more than 50 years old with symptoms for more than 5 years. If the patient has cancer risk factors like smoking and chronic alcohol intake, they should also undergo endoscopy during the initial evaluation of GERD. Finally, the presence of the alarm symptoms should prompt endoscopy. Alarm symptoms include hematemesis, persistent vomiting, melena, anemia, weight loss, dysphagia, and odynophagia. These symptoms suggest the ominous cause of GERD, like cancer. Management of GERD includes administration of proton pump inhibitor once daily for 2 months. If the patient has refractory symptoms, then we can either switch to different PPI or increase the PPI dosage to twice daily. Alternative medications include H2 receptor blockers like cimetidine and ranitidine, and antacids such as magnesium hydroxide and calcium carbonate. It's worth mentioning that proton pump inhibitors are preferred over H2 receptor blockers because PPIs best suppress the gastric acid production. Antacids, on the other hand, are for symptomatic relief. A 75-year-old man presents to the physician due to occasional chest pain, heartburn, and sour taste in the mouth for 6 years. Chest pain has recently worsened, prompting him to seek medical care. He started taking omeprazole 2 days ago without any significant relief. He's been smoking 2 packs of cigarettes per day for 30 years. He also takes naltrexone for alcohol use disorder. Baseline ECG and exercise stress tests are unremarkable. Vital signs include temperature of 37 degrees Celsius, blood pressure of 135/80, heart rate of 85, and respiratory rate of 15. Which of the following is the best next step in the management of this patient? A. Continue omeprazole once daily for the next 2 months. B. Prescribe omeprazole twice daily. C. Switch to pantoprazole once daily. D. Endoscopy. This patient presents with occasional chest pain, heartburn, and sour taste in the mouth for 6 years. Considering that baseline ECG and exercise stress tests are unremarkable, his symptoms are best explained by gastroesophageal reflux disease, or GERD. Since the patient is more than 50 years old and his symptoms are present for more than 5 years, he needs to undergo endoscopy to look for ominous causes of GERD like esophageal cancer. He's at particularly high risk for esophageal cancer considering his smoking and drinking history. So the correct answer is option D. Here's a slide reminding us of the diagnosis of GERD. Please note these clinical scenarios when endoscopy is indicated during initial evaluation of GERD. Let's discuss why other options are incorrect. Option A is incorrect because continuation of proton pump inhibitors once daily for 2 months is indicated for patients without alarm symptoms. This patient, on the other hand, has multiple alarm symptoms. Option B is incorrect because we need to escalate proton pump inhibitor dosage only if once daily proton pump inhibitor is ineffective. Finally, option C is incorrect because we may need to switch one proton pump inhibitor to another only if the initial medication is ineffective. And that concludes our lecture on diseases of esophagus.